Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD co-founder and CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. Eric Wallace. Dr. Wallace is a native of Alabama. After completing a clinical fellowship in nephrology, Dr. Wallace joined the faculty at UAB, where he earned numerous accolades, including being elected by his peers for the C. Glenn Cobbs Award 2 years in a row as one of the top 10 clinicians in the Department of Medicine. Dr. Wallace became the medical director of Telehealth for UAB in January of 2017, given his work on telehealth for home dialysis in patients with Fabry disease. He received the Dean's Excellence Award for Service in 2017 for his work in telehealth. Under his leadership, numerous outpatient telehealth programs have been initiated and are in the process of expanding. The initiation of programs such as telestroke, telecritical care, and telenephrology have resulted in significant improvements in delivery of care and revenue in rural hospitals in Alabama. It is his hope that the natural progression of telehealth will be an answer to decrease rural hospital closings, support local rural physicians, and thus improve physician recruitment to the areas, and to improve disparities in care across the country. Programs delivering care directly to a patient's home with or without the assistance of home health nurses have also been started under his leadership with the goal to improve access and efficiency in care. Finally, the UAB e-medicine program is implementing remote patient monitoring to prevent disease before they culminate in expensive hospitalizations and improving health. Dr. Wallace, Eric, welcome to the show.
Thanks for having me.
Amazing. So actually, Eric, we chatted a little bit before the recording started, but I cannot think of a better guest to get on the show to talk about telemedicine and telehealth. You've really been a pioneer for the past decade on everything telehealth and bringing it to UAB and really helping Alabama scale out telemedicine across the entire state. But I think it's interesting, prior to working in the world of telemedicine, even before your career started as a nephrologist, you appear to have always been academically inclined. An example I found is, you attended the Donahoe School, which is a prestigious K-12 school focused on academics, imagination, and leadership. And then you actually pursued a bachelor's in Spanish. And so my question is, at what point did you realize you were meant for healthcare, and how did that happen?
So that was about 3 years of age. So my dad's a doc, and back when I was a child, HIPAA wasn't as big a deal, and so it's one of the things I really kind of lament, because I would go with my dad to round at the hospital from the time I was probably around 3 or 4 every single weekend. Like, that's what I did. I woke up when he left without me. I got angry, and he told me that so when I would fall asleep, because occasionally I'd fall asleep on rounds, and he would just put me in one of his patients' beds. And, so when I was 18, I ran his lab, and I would have patients, and they were like, I remember when you were little. Wow. The reason I lament it a little bit is because that's how I got exposed to medicine. And when I went into medical school, I knew what medicine was. I knew what it meant. And so, I think that a lot of people who get into medicine nowadays, they think it's lots and lots of money for little work hours, and it's Grey's Anatomy, and so they get kind of disillusioned with it once they're actually in it. But if you grow up knowing exactly what it is and you still choose it, then you're not disappointed when you get exactly what medicine has always been. So that's how I got into medicine. It was seeing him, and one of the things I hope I am doing, which is he was primary care, so he established relationships with his patients. I mean, long-standing relationships. One of the things he always did is when any of his patients turned 90, the entire family went to the birthday party. So we would go to the birthday parties of the 90-year-olds that he had. And, you don't see that as much anymore, but it was growing up with him. I knew exactly what I wanted to do. The bachelor's in Spanish is kind of also not as far as I was academically inclined. I actually got accepted to medical school out of high school. I did the early medical school acceptance program, which they accepted 10 people in our state. And since I knew what I wanted to do and had the grades, I got in. But because of that, I didn't have to major in, I didn't have to take the MCAT, which was fantastic, but I also didn't have to major in science. I had to do all my prereqs, but I didn't have to major. And my mother actually was an illegal immigrant from Chile. So my dad's from California. He met my mom when she came in, and 3 months later they got married. They moved to Alabama. That's why I was born here. But none of them, I'm first generation Alabamian. But half my family still lives in Chile. And so I grew up speaking Spanish because my grandmother lived with us and only spoke Spanish. And so I started as a biology major, but then after about 3 months in college, I said, I want to go visit that side of my family. So I went there for a month. I visited my grandmother, who actually, when I was 14, moved back to Chile, and I loved it. And I, it was the best decision I made, because after I got fluent in Spanish, one of the things I wanted to do was do Doctors Without Borders in Latin America. That was my first goal. So I did malaria research in Peru. I did pediatric work in Costa Rica. I got a Rotary scholarship to go to Mexico for a year. And it was all geared, how do I help those folks? But then you started realizing that, Alabama has its own third world issues. And there was actually quite a few Hispanics. Hispanics are predisposed to chronic kidney disease. So I actually moonlighted, quote unquote, as a medical interpreter here at UAB while I was in medical school. And now, it's just, communication is so much of medicine. And I get to communicate with patients who really are underserved or misserved by our current. And the reason I say misserved is I've spoken to patients who, even though we have the access to interpreters, because of time, a lot of times the docs go in, they don't use them every time, right? It's like get in, get out. And I've had patients who come up to me and say, I ask them, what do you understand about why you're in the hospital? And they're like, I don't know, because nobody's told me. And so communication, I would think that most people, there's a lot more medicine that's art than science. And I'd actually encourage anybody going into medicine to, choose a language or an art, so that you can understand that not everything is black and white and has an answer, which is really what the Spanish major did.
And Eric, I guess maybe you answered this, as I know you mentioned there was an interest in chronic kidney disease. Was that the reason you ended up in nephrology in particular, or was there some other light bulb moment for you?
Well, yeah, the light bulb moment. For some reason, during, I always say that because I wanted to do infectious disease with Doctors Without Borders. And what you'll realize is that the two nerdiest medical specialties is infectious disease and nephrology. And so in medical school, I actually loved the renal module. So every single year, from basically third-year medical school on, I would choose the renal module, and I loved it. And finally, it dawned on me after the fourth time, was one of the reasons I always got to do the renal module is because, first of all, nobody else wanted to do it. So I was like the one person who was choosing it. The second thing is that there was a patient that I had that I'll never forget, actually a Hispanic patient who had strongyloides. And I started thinking to myself, I'm like, look, I love infectious disease, but the only really, really cool infectious disease that I've diagnosed has been on renal. And then I started saying, well, we have HIV nephropathy. We have transplant that also has all their infections, and I get all the cool physiology from the kidney. So I loved it. And I love the patients because, really only second to primary care, or really just on par with primary care, is the relationships that the nephrologists develop with their patients. Once you're a chronic kidney disease patient, you're going to be seeing a nephrologist for the rest of your life. And I love that aspect about it. So it really, for me, it was, I tell people that nephrology is internal medicine, which I always loved because you get to do everything, but it's with a PhD in the renal function panel. So we know that little box really, really well. And then it turns out that I started, when I got into nephrology, although I liked the glomerular disease, I liked the autoimmune, the infections, et cetera, I started really liking dialysis too. And unfortunately, dialysis has gotten a bad rap. When we teach people about nephrology, a lot of times we go, oh, I'm sorry, we have dialysis, right? We look at all the other cool stuff we have, but there's dialysis too. But for me, dialysis is just the opposite. And I frequently tell people, I'm like, look, in 1960, everyone in this dialysis unit would be dead without these machines. And then you go through the history of all the things, the innovation that has occurred to make this happen, right? And then it just starts changing it. So, I got into home dialysis, which was even more fun because you got to take care of patients at home. But yeah, I absolutely love my specialty. I actually love it when people remember that I am still a doctor, because a lot of times people just associate me with like iPads and technology, but I'm like, I'm still a doctor and I still love what I do. And it's because I love what I do that I got into the technology as a means to do it better.
It's funny, Eric, that you mentioned that nephrology and infectious disease are, quote unquote, the nerdiest specialties. I remember when I was in medical school, two folks I remember who knew from the start they wanted to do nephrology and are doing that now are two of the most brilliant people from my class. So I can definitely see why that attracts folks like yourself. You mentioned the technology piece, and hopefully not everyone at UAB thinks that you're just the IT person, but clearly something drew you to telemedicine a number of years ago. How did that happen for you?
Yeah, I tell people that, probably the theme of all of this is I usually gravitate towards things that no one else wants to do. And so, I'll give you an example. So when I came back from Vanderbilt to UAB, my division director said, "Hey, do you want to do home dialysis?" And at that time, I wanted to do glomerular nephritis research on imatinib. So I was doing tyrosine kinase inhibitors as an immunomodulator, right? It was all basic science and, I guess translational work, right? And so when they asked me about the home dialysis, in my head, I said, hell no. But what came out of my mouth was, thank you for the opportunity. Right? And so then I started seeing the patients and I loved it. But I realized, if you look at Alabama's dialysis population, it's kind of staggering to think about the numbers, right? Because we all think this dialysis is so many patients, but in Alabama, we have 4.5 million people. We have about 11,000 dialysis patients. And at the time, only 10% were on home. So there were literally 1,000 people in the state that were on home dialysis, right? And UAB took care of roughly about 20% of them. So where were those patients coming from? They were driving hours to see me. Then, so my mentor, Dr. Warnock, who actually was the first person to put a patient on Fabry disease or with Fabry disease on Fabrazyme in 2003 when it became commercially available, he said, "Hey, do you want to do rare disease with me?" I said, "Sure, why not?" So I took over the rare genetic kidney disease clinic, right? And guess what happened? Patients were driving hours to see me. So what I said was, one time I was talking with a patient who was saying, they drove 3 hours one way to see me for a 15-minute visit for peritoneal dialysis. I did that every single month. And they came another time to get labs. And then they had their endocrinologist, their cardiologist, primary care. And I started thinking to myself, I was like, look, we are part of the disease, right? Our healthcare is part of any disease. And so I started imagine a disease that has 0 symptoms, right? But I want that patient to come, in order to maintain 0 symptoms, you have to see the doctor every day and wait in that waiting room. And then you realize that's a miserable disease, right? So it takes away from their quality of life. So I mentioned to one patient, I was like, I think I could do this over telehealth. That was early 2013. And I was doing basic science. I changed my basic science focus to peritoneal membrane failure. So I was looking at glucose transporters on peritoneal membrane cells. I just remember after about a year and a half, I had said telehealth once, and I was working towards that, but I was also working towards my KO8. And I submitted my KO8, and I had the realization that if I got the KO8, I'd have to tell all my patients no to telehealth because there wouldn't be time. But then I realized that although my patients would participate in my studies, the only thing they asked about every single time they saw me was, when's the telehealth coming? And then I said, look, if the patients are driving this, the patients are saying they need somebody to do it, and that has to be me. Because at that time, I looked around UAB and I wanted to find the person, right? I needed to find the person who did telehealth because it's UAB. They had to have somebody. And I looked everywhere and could not find that person. And then I went to the state to see if somebody was doing it. And there was this Alabama telehealth interest group. And there was always 4 people there. I was like, Jesus, we got to, somebody has to do this because the patients were begging for it. And that's how you knew your compass was right. So even 10 years ago, if the patients are saying, this is what I need, that's because a lot of times what happens is you have a doctor telling the patient what they need, right? And then we tell the legislators, this is what the patient needs.
Mm-hmm.
But this was one of the first times where the patient was saying, this is what I need. Why don't you work on this? And that's every time somebody told me I was wrong, I went into multiple departments, and the departments were like, why do you want me to do this? And I'm like, it's right because the patients need it. And that's what kept me going.
I think it's one of those things where David, Eric, I don't know why I said David. If you put yourself in the patient's shoes and you think about, well, if I had to travel 3 hours, it seems common sense as a patient that I'd want telehealth, but I guess if you're not the one in those shoes, it's hard to realize it. I think Alan, you were doing some research, and I think you found that it was quite a bit of an uphill battle for Eric to bring telehealth to UAB.
Yeah, so it sounds like, in 2013, that's kind of when the genesis of this idea came forward about telehealth. But then it sounds like there was about 2.5 years of regulatory back and forth before you could actually have that first patient visit via telehealth. And so, what kept you motivated that whole time? How did you get it off the ground despite so many barriers and so many roadblocks from regulation?
Well, that was all the patients. And specifically, one of my first patients who was 90, the first patient I did was 90 years old when, actually, I guess she was 87 at the time. But, she kept on asking about it. So I said, I gotta do this. But, the regulatory thing was, there was so much to it. And then you really start realizing that telehealth, the technology is the easy part. The tech is easy. It's tech regulations as it applies to healthcare is tough. Operations is even tougher. How do you get this? Docs like to think of themselves as, and I might tick some people off, but I've met many physicians who think that they're the only person that matters in the visit. But what they ignore is that there was a whole group of schedulers. They have to understand telehealth. There was a whole group of billers. They have to understand telehealth. There's IT, because when something goes down, somebody has to back it up. And then there's an electronic medical record, which has no information on telehealth. There's also billing, right? And so, this wasn't a FaceTime, right? At the time when I did this with my patients, there was no reimbursement for telehealth, zero, in the dialysis population. And since it was going to be the first in the home dialysis population, I didn't want people to come back and say I was delivering substandard care. I mean, I prided myself in being, this great clinician. I didn't want people looking down and saying, oh, that's not good care, right? So what I had to plan for is doing everything that I did in person, I had to do it remotely. So, and then I had to, convince my boss, who was last year's ASN president, that, look, give me the time to do it. So I got a grant from Baxter, who's a home dialysis company. So I didn't have to worry about where the patient was. So the big thing now in Congress is, making sure that the originating site can be the home, right? So at that time, I had a grant, it didn't matter. But I asked all of my patients who were rural, underserved dialysis patients if they could do this in their home. And in 2012, it was a 100% no, right? So I had to develop a network where these patients could go into these facilities and have their telehealth visit. So that was problem number one, because now I needed an IRB for UAB. I needed an agreement with my dialysis provider because these were dialysis patients. And I needed an IRB at the county health departments or at the ADPH because they had their own. So that right there is huge, right? But importantly, the other thing that we had to figure out was we had to figure out how do we, and this is still an issue, which is when you're not using the home as the originating site, how do you make sure that the patient, the county health department, and the doctor are already at the same time? It's one thing if you're using the same electronic medical record, right? But you're not. So you're using a different electronic medical record with a different staff that you don't have any control over. So what would always happen is that, I'd have my clinic, I'd say, I'm ready at 8, right? So my scheduler would call the ADPH and say, could you be ready at 8? And they said, yes. And then we call the patient says, I can't be ready at 8. And then it starts the whole process over, right? And so once you add just a third location or a third person involved in the scheduling, the complexity goes through the roof, right? We had to figure out, how do we get labs? how do I listen to the heart and lungs, right? So we purchased Littman stethoscopes at the time. Littman got purchased by Echo. So I wanted to listen to the heart and lungs. Like I said, I didn't want anybody telling me I couldn't do it. And then how do you get labs, right? That was a big one because somebody had to fill these tubes with labs. Luckily, the dialysis provider used a centralized lab. So even our unit shipped the lab somewhere, but we had to coordinate all of that to get these patients seen. And it took us forever, but it was better for the patients and the patients liked it.
I think one of the really smart things that I'm hearing, Eric, is that, I mean, you could have, if you wanted to, start with a much simpler use case that didn't require all these additional support pieces. So for example, let's say your first use case for telehealth was post-op follow-up for a gallbladder surgery. Well, you don't have to set up networks and support for dialysis and those kinds of complexities. But because you chose with a very complex case to start with all these different variables involved, you knew if you could solve the most complex use case for telemedicine, everything else would actually be easy relatively. So you started with the very complex, and then everything else can just be extended to later on.
But the thing is, I had to, because in this case, I didn't go into nephrology saying, hey, I want to do telehealth, so let me find a use case. I had the patients that I wanted to help, and they were the most complex. And so that was my use case. That was the only use case. The same with rare genetic kidney disease, right? Is that I had a very complex use case to solve for. And I was never enamored with the tech, right? I'm not in this because of tech. I'm in it because it helps me take care of patients. So it was my only use case to solve. And if I didn't solve that, I wasn't going to do telehealth. But the beauty of it was, since we started that, right, then nobody could say, if I could take care of a dialysis patient, then you realize you could take care of anybody, right? And if you can take care of anybody, then you start saying, hey, wait a minute, we can completely redesign healthcare, right? This is not urgent care. This is not anything. We can deliver highly complex care across a system. And that actually makes the whole notion of a healthcare system that can take care of a population of people viable. And that's really what prompted all this, but it was really just to help my patients.
It's funny that you mentioned that, because, when we started Seamless MD at the very beginning, we didn't really have I'll be honest, it was kind of accidental, the use cases we started with. So we could have said, hey, let's start with a low risk, easy population, I don't know, foot and ankle surgery with low risk of complications, and, younger populations, et cetera. But just by chance, the folks who were most excited about our work were, physicians working on high risk populations, major complex surgery with high readmission rates. And so that's where people had real pain points. We said, oh, okay, sure. If you're the most interested, we'll do that. But in the same way, because we were able to, build something that the oldest, frailest, most complex patients could actually engage with, it became really easy to engage the young, healthier folks too. But if we had started with the young, healthy folks, I think it would have been much harder to work up to those most complex cases. So wasn't planned out, but it actually in the same way turned out for the best. So that's actually really funny.
Yeah, no, I agree completely. It's just, once you realize, and then you start saying, UAB has a full teleICU where, we're taking care of truly the sickest of the sick. And then we realized we could do dialysis remotely with techs going in, but nephrologists evaluating the patient. You say, now we can change the whole outlook of rural hospitals. We can do remote patient monitoring, which is lower acuity, but you knew that you could design the operations to work. So yeah, it's kind of, you never know what you can do until you try. And unfortunately, I tried with the hardest first, but the patients would not let me put it down.
Yeah, that's incredible. So actually, Eric, I just want to segue a little bit back to Josh brought up Seamless MD, and I think it's a good segue into the conversation with UAB and Seamless. As part of your kind of overall telehealth strategy, your team partnered with Seamless to digitally engage patients before and after surgery with care plans, remotely monitor symptoms. And this, clearly through research and over the years, it's proved to improve the patient experience and clinical outcomes, things like reductions in length of stay. I'm curious though, how does digital patient engagement, how does that concept fit within more of the UAB broader strategy using Seamless MD?
Well, what we can talk about is just digital engagement in general, right? I mean, so, UAB is engaged in multiple avenues of, remote patient monitoring, patient engagement, right? So we have Dr. Gabrielle Rock, who's been involved in patient-reported outcomes monitoring and oncology bundles, right? Obviously, Daniel Chu, who's been using remote patient monitoring in the post-surgical space. And then I largely have been the medical director for remote patient monitoring, specifically as it relates to diabetes, hypertension, and heart failure. And once again, when you start looking at what can be accomplished when you have technology that really is easy to use and enables patients to transmit data, and then you have the operations around it, right? So I always tell people that software never saved anybody, ever, right? With probably one exception, which is if you fall with the watch and then it calls 911. Yeah, I mean then software saved you, right? But even then, it wasn't the software, because what happened is you transmit it to a person who is able to intervene, right? So almost all of this, and I think when all of this comes, is the most important thing is ease of use for the patient, right? It can't be onerous. And then the second thing is the operations, which is what am I going to do with the data? And I would argue, and frequently do with many vendors, which is that if you don't have a plan with what you're going to do for the data, I don't even want the tech, right? So unless I have that plan, right? And so that's the key. And I'll give you some examples of remote patient monitoring. There's a trial by the name of BEAT-HF, BEAT-HF. It's a fantastic trial, randomized controlled trial of heart failure remote patient monitoring. And the outcomes were negative, meaning that remote patient monitoring versus placebo or versus standard of care in a randomized fashion, 800 in each arm, right, did not cause a difference. And there were two things that actually showed that, right? Or the reasons for those were very apparent, which is when they started the trial, it was patients who had a primary diagnosis of heart failure, right? But then they couldn't enroll enough patients. So then they said anybody with a diagnosis of heart failure. So now you get the patient who went into the hospital for a UTI, they got a dose of Lasix. So the coders were like, hey, code them heart failure. And those are the patients who probably didn't need remote patient monitoring. So importantly, you got to figure out who you're going to monitor. Then it has to be easy. And then the second thing, the other thing that we talked about was the intervention. So the intervention was, if you have an issue, the nurses called the ER or called the patient to go to the ER. Well, if you have a group of nurses calling patients to go to the ER, guess what's going to happen? They're going to go to the ER. And so once again, you have to have a plan to say, if I get this data, what am I going to do that doesn't just result in more ER visits, more hospitalization, et cetera. And I think that UAB is on a good track to actually use these tools, leverage what we have here, design the operations so that it's not just tech that is independent of the operations.
It's a great point. I think one of the mantras we have here is technology is just a tool, but the quality of the implementation and the execution is what makes the big difference when it comes to is it actually driving an outcome and value. So I love that approach. We know that yourself and UAB, really values, improving access to care and removing barriers to access. And, one of the things that UAB has really, I think, shaped our views has been how do we actually improve or support better health literacy? And so, for example, in our partnership, we've made sure that content is at a grade 4 reading level on the platform. I'm wondering, what are some other best practices you've come across to improve access to telehealth and adoption overall?
Yeah, that's a good question. Actually, some of the work has been done in, I hats off to Hopkins, UCSF, and Stanford. And one of the things they did up front when they realized, I guess first you got to define what's a disparity, right? What is the problem with access when it comes to technology? And what most people are saying is the disparity is patients doing phone visits versus or audio only visits versus video, right? So at this time, UAB has done over 500,000 telehealth visits since the beginning of the pandemic. And currently, I mean, when we started, it was almost all phone, and then the video kind of, swept up. And I think our latest number, telehealth is about 22% of our total ambulatory volume currently, and 77% of that is video, right? So there's still 23%, which actually matches up with about the total population in Alabama that doesn't have access to internet. So when we start, what's best practices? The first best practice is what Hopkins and Stanford did, which is that there's a portion of patients out there. One of the biggest disparities is actually age. So if you look at the correlations, as you age, you are less and less likely to use video. Now, nobody has delved into that because that could be because you have more comorbidities. So people are less comfortable with you being at your home. But there's another portion of this, which is maybe you have a phone, but you may not be the best at using video. And I love my mom, but she is usually my test case for all things tech. I say, if she can do it, we're good, right? So anyway, so the thing is, what they did, they got telehealth educators, right? And so they said, they devised a telehealth score, which is, are you a portal member? Yes, no. Are you scheduled for a phone visit? Yes, no. Have you had a video visit before, right? If you had a video visit before and it was successful, great, you don't need me, right? But out of that high risk group, they would actually call the patient, say, do you need help, right? If they couldn't do the test, then you can say, well, what is my intervention going to be, right? So most of them they could get on by just helping them do the visit, by doing a test and coaching through it. The other people, you can say, well, there's public Wi-Fi access spots. You need to be in a private location, like in your car, but use this Wi-Fi. And then, the thing that I think that Alabama can do, we are working towards that now. We have hired our telehealth educators and have a potential to do something that other states don't, because based on the work that we started with, 65 of 67 county health departments in Alabama have state-of-the-art equipment. So now what we're going to do is have telehealth educators try and get them in the home. They can't do the home. Then it's, hey, why don't you go to one of these sites, right? So that we can get to 100% video without requiring the patient to have anything. Because that's truthfully, the only way to have zero disparities when we have access to internet issues, device issues, and literacy issues, right? Tech literacy issues. The only way to get to 100% no disparity is actually to make sure that the telehealth requires the patient to have nothing, right? And interestingly enough, we start talking about the hard models, like developing this network of telehealth locations. Trying to provide telehealth to the most disparate patient population, which is what this was designed to do, is actually the hardest form of telehealth. It's very easy to get telehealth into a 20-year-old's house who has a phone and 100 megabytes of download speed, right? But that may or may not be the person that really needs it, right? The person that really needs it is the person who is disabled, underserved, poverty. Those are the ones that need it, and those are precisely the ones that we're not reaching unless we develop other ways to do this. Reading level is incredibly important. They have to understand it first, but there's other issues as well, which is just access to the tech in general.
Eric, that reminds me, one of my most thoughtful moments during my training was when I was doing work on house calls for the homebound elderly. And back in the 50s, I think 40% of North American physicians were doing house calls. Now it's less than 1%. But then you realize we designed primary care, at least pre-COVID, was built around the clinic model. So for everyone who can ambulate and get into clinic properly, great, you get primary care. But for those who are homebound and elderly and have cognitive and other physical challenges and they can't come into the clinic, well, good luck getting primary care in the past. And maybe telehealth has definitely helped with that. But for a long time, the folks who needed it most can't get primary care. And so your point about how do we make it so that everyone gets access really, really resonated. I mean, do you think we'll get to the point where maybe it's just actually so cheap to provide devices and connectivity that, we'll just ship every patient a connected device. We don't actually care if you lose it or keep it because it's so cheap at some point in the future. And it's actually cheaper for us to give it to you so that you actually get better healthcare and lower costs, further downstream. I mean, that can't be too far away, right?
Yeah, well, it's kind of interesting in how do you address it. So, first I want to have a comment on your thing about the ambulatory patients. So, one of the things that I cringe about, but my patients loved it. So I had a couple of patients who had congestive heart failure, right? And so you look at UAB, you look at our institutions of medicines, right? And so where do we put the heart failure clinic, right? We make the patient walk a mile from the parking deck to the heart failure and the COPD, right? So, and by the time they actually get to the clinic, they've run out of oxygen and we have to refill their oxygen so that they can get back to the car. And you're like, So when we started doing this in the county health departments, right? The first thing they told me, they said, I love this because first of all, they get to preserve their dignity, right? I mean, the last thing I'll give you, if my dad was in a wheelchair, he would not want people seeing him that way. So he's like, well, now I don't need a wheelchair, right? So, some of our patients, they don't need a wheelchair unless they're walking a mile. So in this case, what they could do is they parked right at the ADPH door. They walked in, they preserved their dignity, they preserved their oxygen, right? They did their visit and they walked out with dignity. So some of this, as far as decentralizing some of this care, also is little things like the distance we force patients to walk when you have these giant meccas of medicine, right? And telehealth can really help with that. As far as shipping the devices, I think we're already starting to get there, right? And specifically as you look at remote patient monitoring. So in remote patient monitoring, the CMS codes require that you ship devices, like you provide the devices, right? Well, why would we provide the devices, right? And the reason is that when you look at value-based care, there is a subsegment of the population that if in a value-based care model, if we improve their health, then it will far exceed what the cost of the device is. So most remote patient monitoring programs, CMS only started paying for remote patient monitoring about 2 years ago, right? So before that, remote patient monitoring was already taking a foothold, but it was, I don't care if I get reimbursed anything because I'm going to make it work because I am at risk for a certain patient population. Now, what will change is the threshold, right? So meaning that right now, it's actually a relatively high bar as X patient is costing X and I need to improve upon that. So let's say I set a bar of $20,000 per patient per year. And I say, those are the ones I don't care. I'm gonna flip the bill for the cost because I need them to do better because of economics. As the tech gets cheaper and cheaper, then what will happen is that threshold will drop. But there is a line, and I don't know where the line is, right? Which is that where is the line between public health and healthcare, right? Because historically, the act of just keeping people healthy has been a public health thing. Because if you really look at population health, some of the biggest advances we can make in population health have nothing to do with the healthcare system, right? It's elementary school, it's high school, it is teaching health education and saying this is what you need to do. It's kind of driving this whole mentality that you need to care about your health because a lot of patients, especially based on how expensive healthcare is now, right? I mean, I think the stat is it's 60% of bankruptcies at this point are healthcare related, right? And so now you have a group of patient population, they want health. They want nothing to do with the healthcare system because they're terrified that, they're going to be robbed and have no money. And so what do we do with that population that we never engage with? Now, for those purchasing a monitor, maybe, but what part of this is our own responsibility? So what I do think is that we have to draw some sort of line of what is patient self-responsibility of taking care of themselves and making sure they're healthy versus what is the responsibility of healthcare. And I think that there's still this idea in the United States very much that I'm not going to go to healthcare. If I go to healthcare, there's a pill that can fix me, even though I've spent my entire life getting unhealthy, right? And so we really got to do a better job on the front end, on the public health side, so that we don't end up with some of these problems. But that line with value-based care is getting skewed a little bit, but most of the time, by the time they're in a value-based care population, it's specifically, for instance, Medicare Accountable Care Organization. It's way late. I mean, Medicare is 65, and we're like, we could have started this when they were 18, but there's still a disconnect in people that getting access to care largely because of this financial barrier that the United States, we have a long way to go as far as reducing cost of care for people.
Yeah, and I think one of the challenges is that even like the payer model has its limitations. I mean, we're up in Canada and we've universal single payer model. Our outcomes are pretty near the bottom of the pack among developed countries, and so there's definitely a lot more to it than just even the payer model. And I'm curious to find out, if there are going to be certain states or counties or regions that are going to be forward thinking to what you described and figure out, at least at a local level, how do we make public health and healthcare actually collaborate and create the right proper incentives to connect those two? I mean, I'm not sure if certain public health departments are now contracting health systems to collaborate. I don't know how that works, but that's actually a really great question. And hopefully we get better at it.
No, yeah, and I think we're going to have to realize there are going to be some healthcare things that healthcare can't fix. And one of this is free will, right? Which is that, I almost liken it to the COVID-19 vaccine, right? Which is that, if you look at a metric for access to care, the COVID-19 vaccine has plenty of data. It works, right? It was free. It was everywhere. And at least in my state, we still have, I believe, under 50% of people that are vaccinated, right? Alabama was by far the least. So how do you engage in people who really just don't want to engage, right? And actually, if you try to engage, run the other way. And, unfortunately, I think probably the next 10 to 20 years of healthcare, we're going to have to understand that we have lost a lot of trust. So when you look at what, people in healthcare understand this, right? So we go to a medical conference and we destroy a paper, right? I mean, it seems like every medical conference that you go to where you're looking at a journal article, nothing is ever good enough because we debate it back and forth and we say, does this outcome mean X, Y, and Z, right? And that's fine when you're in our setting. But what we did, we took that public. And when you take that type of discussion public, people start trusting you. They say, you don't know what you're doing. I don't trust you, right? And I think we flip-flop so much on the guidelines for what we did with masking, what we did with vaccines, what we did with everything as it relates to COVID. There was so much flip-flop. I think we've lost a lot of trust. And they said, do these people really know what they're doing, right? Not with everybody, but definitely with, probably half of my state, right? So I think what we need to do, as we deploy technology, we need to ask ourselves another question, which is this technology going to foster trust or is it going to hurt trust, right? And I think the more complex you make things, the less likely the more likely it's actually going to foster mistrust. And one of the pieces of technology that I would love to use, but we just can't yet, is actually text messaging. So, text messaging is not HIPAA compliant in the United States. It is ubiquitous. People use it all the time. It is asynchronous, so it saves people money and time. I don't answer my phone, but because of this law about privacy, we don't get to use it. And I think if we could come a little bit of ways and using texting and things like that to make it even easier for the patient, I think we'd actually use technology to get a little bit more buy-in. But I don't know. I mean, this is a problem that I'm not sure that it's going to take a lot of people to solve. But one thing we have to do is reduce the cost of care, right? Your level of trust goes up a little bit when you're not forced with, the decision of take care of myself or get bankrupt. I think that's going to be important. And the other thing, it's going to take a lot of relationship building, which, we got work to do.
Yeah, I think it's neat that, it's kind of come full circle, Eric, in the conversation, how you first talked about how your father was in medicine. He really established relationships, and that's what his focus was. And it's almost like we've strayed so far away from how it used to be back then. I also think it's a common misconception that, we view telehealth as this patient to provider communication, one-way communication, sometimes two ways communicated. But you were actually involved in another project that I wanted to bring up. It's a little bit off topic from what we were just talking about, but Project ECHO, which stood for Extension of Community Healthcare Outcomes. And I think this type of project could be used as a solution, or at least as a conversation starter for what we were talking about with regaining public trust and working between providers to get this again. Could you just share what Project ECHO is and was, and how it can be used to create more efficient, effective care?
Yeah, I mean, Project ECHO is, it was a great idea from a doc in New Mexico. And basically the idea was simple, which is that, so a brand new miracle drug for hepatitis C got created, right? And all of a sudden, the only people using this hepatitis C drug were hepatologists and infectious disease. But the number of patients with hepatitis C was so great that they said, look, I could see everybody, only Hep C all day, every day, and it would take me 10 years to actually get everybody treated. So what they said is, look, this is easy enough, right? I mean, prescribe the pill, and then once a week, right, I'll get on and help all of these providers, teach them about the pill, help them treat their symptoms. While I'm helping this person treat this patient's symptoms, everybody else listening will actually benefit, right? I mean, this was like the surgery amphitheater, right? This was, hey, I'm talking, this is how we learn in residency. And that's what it was based on, which is that you round in teams, you have an expert teaching one patient about this person, and everybody learns. It was disseminated knowledge. So that's the idea behind Project Echo. Now, the beauty of Project Echo is I mean, I guess the key to Project Echo is choosing your topic, right? Because not every provider can get on an echo for every single thing, right? So what you need is things that are very high yield for a large group of people that see a lot of those patients, so you can disseminate the care of patients from the expert to the primary care providers, how this was designed, right? So the way that it can help with care is that you actually elevate every healthcare provider. I mean, and it's interesting, we always want data, right? I mean, so everybody says, oh, well, there's no data that this patient did better. I'm like, have we ever needed data that healthcare education improves outcomes, right? I mean, one of my favorite sayings is that the patient usually does better if the doctor knows what's going on with them. And so, that's probably true. And so, this is just a great way. It's case-based learning to improve access to care. And one of the things that is very interesting is that the dissemination of data. So you have academic medical centers, which are in general about 7 to 8 years ahead of the standard of curve everywhere else, right? Well, medical knowledge is moving far quicker than we can keep up with. And so this is one way, can't be the only way, but it's going to be one way that we can help combat. How do we elevate everybody to the level of the cutting edge, as opposed to just waiting for it to trickle down for the next 7 to 8 years?
Yeah, I think that's completely invaluable and really could have, served as a great lesson for providers during COVID, right? With vaccines and sharing, disseminating best practices as it occurs.
Yeah, and it turns out that the AHRQ, UAB participated in this in a COVID-19 echo for nursing homes. So we had 40 nursing homes that would log in with our experts to disseminate knowledge of infection control, vaccinations, et cetera.
Right.
So it was a very good way of one of the best things that people said about it was not even as much about the dissemination of knowledge, but it was about collaboration. I mean, people got really lonely. Healthcare got really lonely. Nursing homes got really lonely during COVID-19. I mean, so having that interaction with other people experiencing the same thing you were going through, that was invaluable on its own. So, it's definitely a very important model that we're going to have to work on. The reason we're going to have to work on it, you say, well, why aren't we doing a bunch of Project Echoes? Well, currently there's only 3 states that get reimbursement for it. And so trying to keep providers who are subspecialists into the echo, right, into this hour-long session that they have to dedicate, they have to plan, they have to do slides for, et cetera, has been the issue with sustainability. How do you get everybody, once all of the emergency is done, how do you get people in the private world to log into those echoes, or in the rural world to log into those echoes? It's not like most people are twiddling their thumbs for hours and hours on end. I mean, they have busy clinics, so it has to be worth it. And that's why, for me, there's 2 things, which is we got to have a sustainability model for Project Echo, but 2, we have to, you have to pick the topics. You can't make so many echoes that nobody logs in. It defeats the purpose. And you have to realize that people just can't log into every echo, right? So high yield is probably the best way to go.
Yeah, no, totally agree. Eric, just because we're short on time, we're going to flip over to the lightning round, but we'd love to have you back on the podcast in the future, because there's so much we didn't dive into today, and you're honestly just a wealth of knowledge on the subject. But let's jump over to the lightning round. 5 questions to get to know you a little bit better for our audience. First question that we have is, what is your favorite book or book you've gifted the most?
Oh, so I gotta say my favorite book is Lord of the Rings.
Awesome.
I mean, all of them, but it's because it's fantasy, and all of this. I mean, to think that somebody could imagine a world like this, and then you say, well, I mean, that's what we did. Right? I mean, with telehealth, you imagine this amazing world, and then the whole rest of it is how do you make it true, right? So yeah, Lord of the Rings is probably my favorite group of books.
That's awesome. Question 2, how has an apparent failure set you up for greater success?
Yeah, I mean, so almost all of our telehealth programs begin with a series of failures. And so, we just with, for instance, the home dialysis patient population, one of the biggest things was, how do I get labs, right? And so the first was, well, all right, let's bring patients to the center. But I'm like, if they're coming to the center, then why don't I just see them there, right? That doesn't make any sense. And so then we said, well, why doesn't the county health department, provide the tubes of blood? But there was inducement issues there, right? That's actually paid for by the Medicare bundle. So what we came up with was, we had a box full of tubes, right, which was provided to us under the bundle. Patient would take those tubes because they had to be seen in person once, so they leave with the tubes. Then those nurses would actually do the phlebotomy, but were covered for that, and then ship them to our centralized lab, which was great because I got the labs in my same electronic medical record. So one of my biggest, as a nephrologist, one of my biggest pet peeves with telehealth, and I love telehealth, right? But when I get labs and it's done at a separate lab, they don't go into my EMR. It ticks me off because I like to trend things, right? Well, in this case, we solved for that because they were going to a centralized lab, they were coming, so it's multiple failures. Remote patient monitoring is another one. I mean, we tried, I tell people, I actually gave a talk recently on how we came up with our remote patient monitoring. And my alternate title was 10,000 ways not to do remote patient monitoring because it was just failure after failure. And then finally we said, hey, we got the secret sauce. This works, primarily around logistics. How do you do glucometer strips? How do you get the patient what they need? What happens when the stuff breaks? I mean, all this stuff that we had to design, and most of it, I just tell patients, people, this is the executive director and my mantra, which is that you plan for one patient, right? And then you get that one going, and then you fail a bunch of times. But unfortunately, in large bureaucratic systems, what happens is you plan for perfect, and then nothing ever happens. So I think in healthcare, not in healthcare, in IT, there's a whole word for this, which is you need a minimal viable product, right? And then once you get the minimum viable product up, what do you do? You do iterations, right? You do, every single iOS is a failure that somebody fixed, right? And so that's really when I tell people about getting telehealth programs up, I say, stop planning for perfect, right? Plan for one patient. Don't plan, some people, when you start telling them about telehealth, their brain goes so big that they're like, what am I going to do if this is wildly successful? I have 1 million patients. You're like, you don't even have one patient yet, right? Get one patient, minimum viable product, and then keep failing and fixing the problem. That takes a lot of effort until you get to what's right.
Yeah, that's fantastic advice. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I'd rather have the ability to change people's minds.
Oh, that's good.
I'm usually pretty good at reading what they're thinking. Unfortunately, it usually takes me 5 to 10 years to change their mind. The right way to do it. But yeah, I'd definitely go with reading people's mind so that I could figure out what I needed to do to change it.
Yeah, I love it. Question 4, what is something in healthcare you believe that others might find insane?
I think there's so much in healthcare that's insane right now. I think, cost. When people look at the inflation numbers on how much the cost of care has gone up, right? I mean, it's what is charged for healthcare now is very, very expensive, and we got to say, how do we improve this? Interestingly, I also think it'd be shocking to figure out that many people and many people within healthcare systems actually cannot tell you what the cost is, right? So the cost of, if we go to someone, right, and say, what is the cost of a pneumonia admission to the hospital? you can't figure it out, right? And so, how do we even think that we're going to control cost if we really have a difficult time attributing cost to admissions, right? It's a really hard accounting problem. So I think that's, for me, that piece of it, that we don't quite understand how to attribute cost in a healthcare system is tough.
Yeah, I agree there. Last question that we have, this is a pandemic lockdown related question. What is one hobby or activity you've gotten into since the beginning of the pandemic?
Well, one hobby, we talked about it. One hobby was I got into flying. That was fun, but now pandemic is rolling out and the work just keeps on piling up. So unfortunately, I was pretty close to getting my license. I lacked about 3 hours, but decided that between children and work and all the stuff that needed to be done to keep making healthcare better, there was just no time. So that was the hobby. It was a great thing to do, but now I'm back to my other hobby.
On the ground. Yeah.
I'm back on the ground. Road biking is now my, in college, I did road cycling, did a couple of centuries, 75 miles, but kids got bored and never took it up. But when the plane went away, now it's back to road biking.
No, that's great. That's awesome. I love the picture I saw on, I think it was your Twitter. You shared or LinkedIn shared the photo of you almost getting the pilot's license. So that's really cool. But good to see that you're back on the ground. Thank you, Eric, for coming on the show today. Honestly, you've provided a lot of wisdom to us and our audience. Would love to have you back on the show, honestly, because there is so much more in the world of telemedicine that you could go into. I just want to circle back one thing to what you said in the beginning about how you have this passion for almost like Doctors Without Borders. I just think it's so interesting that you did find your way into telemedicine, because in a way that is kind of, opening up the borders and opening up access to patients. So I just think it's so incredible how it worked that way, full circle.
Oh, well, it is. And, the interesting thing, so I've gotten involved in a project in Cameroon. This holds the key, but when you realize, what are the technologies? And one of the most eye-opening things is I get on text, right? So I was in an international conference on remote patient monitoring and home dialysis, right? And met an individual who was over a system on how do I deliver care in India, right? And one of the things that was eye-opening, which is that it's like people don't have access to data. A lot of them don't have access to phones, right? Just cell service, but everyone had access to text.
Mm-hmm.
So when we start talking about disparities, what you really got to do is go to the lowest common denominator of what people have access to. And they have access to it. And that's why, I think that moving forward, what I would love to say, which is what is the risk benefit of restricting text, right? How many people could benefit, because, privacy and regulations are there to protect people. But there's a point where they do so much protection that they harm, right? And so I think that that's what we're going to have to grapple with, long term, which is the prison of regulatory that we've created, is the fortress of regulatory that we've created, is it really a prison? And do we need to loosen up some of those regulations as it relates? And I think that, my hope is that we can get some, patient groups together and really have them discuss the utility of text, because almost every third world country, if you look at most of what they are doing when it relates to delivery of healthcare across a population, it almost always includes some sort of text messaging, which they think is fine. And, they don't have near the regulatory that we do. The other interesting thing, which is that we were talking about, which was phone, right? Access to audio only, which for us, that's the lowest common denominator, is audio only. But interestingly, in the project that I'm working on, we had to do a telehealth hub for audio conversations. So people had to go somewhere just to get a phone call, right? So I think it holds the key. It holds a lot of benefits for external countries that really need access to care. Ultimately, there has to be somebody on the ground. So, where I started this was there needs to be somebody on the ground with access to subspecialty knowledge. That's what we're doing in rural hospitals. And once we get Alabama out of the bottom 50 as far as healthcare outcomes, then the next place is third world countries.
That's amazing. No, fantastic. Thank you, Eric. We've got to jump, but I think like that could be another conversation into itself. So really appreciate you bringing that up, and looking forward to seeing all the work that you're currently working on really come to fruition. So thanks a
Thank you
lot,
so
Eric.
much, Eric. We appreciate it.